Welcome to today's session on the impact of the pandemic on diversity in academic medicine. We are so grateful to have Dr. Wayne Frederick here. Dr. Wayne Frederick is the 17th president of Howard University and the distinguished Charles R. Drew Professor of Surgery at the Howard University College of Medicine. He is also a practicing cancer surgeon at Howard University Hospital, where he continues to see patients and perform surgeries. He is a true son of Howard, having earned 3 degrees from the university, a BS in 1990, an MD in 94, and an MBA in 2011. As president of Howard, Dr. Frederick has worked to strengthen the internal operations in order to enhance the student experience and position the university to more effectively serve the community. He has overseen a period of immense growth and transformation at Howard, including record-breaking enrollment numbers and philanthropic donations. Dr. Frederick is an expert on healthcare disparities and devotes his time to speaking about and advocating for social justice, as well as diversity, equity, and inclusion. Dr. Frederick also serves on the boards of numerous institutions and organizations, including the Federal Reserve Bank of Richmond and Humana Incorporated. Dr. Frederick is also a member of surgical and medical associations, including the American Surgical Association, the American Cancer Society, and the American College of Surgeons. Dr. Frederick has a packed schedule. He is actually flying to Newcastle today. So we are so fortunate to be able to get Dr. Frederick here to present for 2 sessions today. As you have questions throughout today's session, if you don't mind just typing them into the chat, and if they are super urgent and timely and need to be answered right away, we'll try to work them in. But otherwise, Dr. Frederick prefers for us to hold them to the end, and then he can answer them all at once. Without further ado, I'm going to turn this over to Dr. Frederick. Thank you so much for being here.
Thanks for having me, and thanks for that generous introduction. So I'm going to jump right in because I think leaving as much time for the Q&A is going to be important. So one of the things that I do often, I'm fascinated by is the cycle of history. And when we come upon times like this with the pandemic and we talk about diversity, I often try to harken back to a time that may have been somewhat similar. And that time takes me back to the Flexner Report, which was performed by Abraham Flexner near the turn of the prior century. And this was a very important report. Abraham Flexner took on a very ambitious project, and that was to go throughout North America, both the United States and Canada, and assess every medical school. He was looking for admission criteria, he's looking for preparedness, looking at facilities, resources, etc. What is not often understood or spoken about in its true light is what he found and recommended. And so I'll go over just a few things that he recommended. One was that entrance requirements and adherence to them needed to be beefed up, as it were. He was concerned about the size and the training of the faculty, felt that both were inadequate. The sum and allocation of endowment and fees to support the institution, he also thought was inadequate as well, and questioned the quality of the labs that were there. Some of the relationships between the school and its associated hospitals he felt was, a little bit thin. Kind of sounds like some of the issues that we have today with academic medical centers. But his overall intent was to reduce the physician supply because he thought the quality was poor. So he called for reducing the number of schools that existed at that time down to 31. Annual output of physicians he wanted to decrease as well, and the number of medical schools actually decreased to 85. The number of students decreased by more than 50%. And the percentage of schools requiring 2 years of college preparation for admission rose from 3 to 92. So he certainly changed the landscape of academic medicine. But there were some other important things that he spoke about, and we have to remember the context and the time in which he did this. One of the things he said was that it was clear that women show a decreasing inclination towards medicine. The 7 medical schools for Negroes should be reduced to only 2. Blacks being a potential source of infection and contagion needed their own physicians. and hygiene rather than surgery should be strongly accentuated at these schools where Black students were attending. By 1923, only 2 medical schools for Blacks remained at that time. And then between 1920 and 1964, less than 3% of students entering American medical schools were Black. Unfortunately, today, that number has remained unchanged. And you'll see what happened with respect to the number of women who are applying to medical school. Now, one of the things I talk about a lot is unconscious bias. And so needless to say, after reading that, I wasn't a big fan of Abraham Flexner. And then as I became president, I went to this building, which is called the Founders Library at Howard University, where we store our Moreland Springer and Research Center. And we have papers from all of our prior board of trustees, including Frederick Douglass. And lo and behold, I found out that Abraham Flexner was a member of Howard University's board of trustees from 1930 to 1936, and even served as the board chair from 1932 to 1935. So clearly, despite what he wrote in his report, he was clearly a big supporter of Howard University and of the pipeline to medicine, in spite of that. And so sometimes even when we read about things that we may not agree with, we need to put them in context. He actually worked on the appropriation that brought this building to be, which was intended to look like Constitution Hall in Philadelphia, as the iconic building on our campus today. So one of the things I hope you would take away from this is we all have unconscious biases. They're informed by various things, but we must always be mindful of the fact that we do and work towards making sure that they don't have an oversized influence on our way of thinking. Howard University has always been an ambitious project. The first faculty members of the medical school included 2 African-American surgeons, actually, A.T. Augusta, who's seated here to the left, and C.B. Purvis, second from the right here. Again, the fact that the medical school was not only started right after the Civil War, but was such an ambitious project to train African Americans in medicine at that time says a lot about it. And our founder, for whom we are named after, Oliver Otis Howard, you can see standing here. He's standing with his left side towards us because he lost his right arm during the Civil War. Applicants to U.S. medical schools by race and ethnicity has been a very interesting odyssey. As I said, it has stayed almost constant at 3%, and I've spoken a lot about the lack of African-American men in particular in medicine. And one of the major things that we did see is that number did not change. As a matter of fact, there were less African-American men applying to medical school in 2015 than applied in 1978. And that has been a concern, but I'll draw your attention to something very unique here that has occurred. If you look at Black or African-American only students, you'll see men are at about 1,500, women at 2,800 for a total of 44. And if we come all the way across to last year, you see a significant jump across the board, primarily with women, but you see we went from about 4,300, which was around where it has been consistently, to now 6,167. So clearly, some of the efforts that have been laid out to try to improve this, and I actually think this is one of the things that the pandemic has brought us that may represent a significant change. So only 5% of doctors in the US are Black. Again, not a very big difference from the time of Flexner, but I have some theories about why we had such a big jump last year. You now have students who can do interviews by Zoom because of the pandemic. They didn't have to travel, and therefore students of lower income who may not have had to fly all over the country. The second thing is our process is fairly intimidating, right? We bring students, we put them all in a room. They get to have conversations with each other or overhear conversations amongst the group. And those conversations can range from, I have, 9 more interviews, when you can be a student of very little means. You have 1 more interview, or you can't fly to the West Coast if you're on the East Coast, et cetera. And so what we saw with our students at Howard in particular was that more of those students were able to access interviews and participate, and also did not have that intimidation of getting to a new place, being the only African-American applicant in the room, et cetera. And so we've seen that rise. We'll see if that's consistent and sustainable as well. When you look at the number of active residents in training as well, you see, of course, a similar number, right? 5.5% are Black. What's also interesting is that 16.5% of the active trainees were non-US citizens. And so our dependence, our medical care system, our dependence on that international component of students is significant. And with the pandemic and more difficulty in terms of those students getting into the country, this could be a really significant impact on diversity of the pandemic as well in medicine. So this is yet another thing that I think with the pandemic, we're going to have to look at very carefully. We've all seen slides that look like this that kind of project what the shortage of physicians would be, and therefore where physicians come from, who they are, is going to be important. I think just as important when you look at the practice specialties and you look at males in particular, we've been seeing some trends of concern in terms of those numbers and where those numbers are particularly thin. We certainly have been trying to encourage our students to get involved in some of these specialties, well underrepresented. So a lot of times we talk about minority students and we have a conversation about primary care. And I think one of the impacts of the pandemic is that we may have more students going into primary care, but that could worsen the gap in representation in some of the subspecialties. And I think we have to be careful about that conversation, or at least how we have that conversation with students, to make sure that we don't worsen some of the areas that are already particularly depleted. And same thing for female students as well. I think we have to look at these and see where we have some of the underrepresentation and ensure that we are making an effort to improve what those numbers look like. As I said before, Black male enrollment has been really, really poor until this past cycle, where we had an increase by about 21% of Black first-year students, and it was consistent among men and women. So I think, that's certainly a silver lining, and certainly something that we hope is going to continue and be consistent as we move forward. Now, obviously, being from Howard, I'll talk a bit about what we're doing with that diversity and how we see the pandemic and that impact. Howard was started on March 2nd, 1867. It was a charter approved by the 39th United States Congress and signed actually by the 17th President of the United States, President Johnson. I mention that because he was a known misogynist and known racist. And one of the things that I think today is particularly important for us to recognize is that while we have a democracy that's complicated and sometimes cynicism can set in, and we have to recognize that it works. Whether or not we like how it works, whether or not we think it's pretty or fast enough, the fact of the matter is that it does work to some extent. And with that in mind, this was a very ambitious project. Howard was not started as a normal school or a seminary, as most of our great universities in America were started. It was actually started as a university. What was also unique about it was that both people of both genders were admitted from the very beginning, which was not a practice in higher ed at that time. There have been more white presidents at Howard than Black presidents, which is a little known fact. There have been 10 white presidents, and I'm the 7th Black president. The first Black president was Mordecai Wyatt Johnson, and he started at Howard in 1926. He was 40 years old at the time. And you can see that enrollment was about 1,700 with a budget of 700,000. And by the time he left in 1960, we had about 10 schools and colleges, all were fully accredited. And the budget had risen to about 8 million with a student base of about 6,000. He really changed what diversity looked like, not just at Howard, but in higher ed. He insisted in his contract that in the 4th year of his contract, he would go out and find a Black dean for every school. So at this time, if you look at historically Black colleges and universities, at that time, in our history, they were run by white men and most of the faculty were white. He really began to change that and bring the historically Black colleges and universities into the contemporary experience that you see today. So today, Howard has 14 schools and colleges, 10 within our academic affairs division and 4 in the health sciences. We have a level 1 trauma center, a hospital. We have our own TV station and our own radio station as well. And so this makes it a very, very complicated enterprise. We have about 12,000 students, which is the highest, not just in a decade, but our highest enrollment ever. And our federal appropriation, we're one of two non-military institutions in the federal budget as well. So I like to refer to Howard as the most public-private institution. There's some unique things, I think, about the university. So for instance, when you look at dermatology and you look at Black dermatologists in the country, by my last check, and my chair of dermatology keeps me honest on this point because she didn't train at Howard or attend Howard, but she was the one that brought this to my recognition. Within the past 5 years, 90% of the Black dentists in America either attended Howard University, undergrad, College of Medicine, or trained at Howard University Dermatology Department. And that's an outsized burden, as it were. You know, I think we pat ourselves on the back for being able to have that type of production. But I think for us as a country to rely on one institution to do that is something that we've got to be very cautious of. And so we continue that pipeline with our students. But it's just one example of why that diversity is important and why others have to, join in. I think when you look at diversity in medicine, you can't isolate it because I think diversity in academia is important. And when you talk about the pipeline, we have to think of the pipeline in terms of STEM and how are students pursuing that. So at Howard, we currently have a four-year graduation rate of about 60%. When I started, it was about 38%. The number one reason students don't finish at Howard is because of finances. We have a significant majority of females, 74%. And so again, when we look at where the pipeline is coming from, I think that's something for us to think about carefully. The top 5 majors include biology, political science, psychology. At one point, 2 or 3 years ago, political science became number 1, I think reflective of our country. But the fact that biology and psychology are in the top 3 does represent the fact that we have a strong pipeline of students coming in. So our rankings have gone up significantly, and I think that has resulted in a significant interest in students coming to the university. However, it does create a concern that I have, again, when we talk about the issue of diversity in medicine. We are now receiving about 8,500 to 9,000 applications for medical school. We're only enrolling a class of about 120 to 125. So there's a lot of interest, but the fact of the matter is that we are now the 5th most selective medical school in the country. And that is of a concern of mine. It is a concern of mine because I am worried that as this becomes more competitive, especially if we represent a good opportunity for students, that could be problematic. Now, the other thing that's important to note is that although we are that selective, we do have a selection bias. 79 of our students were not accepted anywhere else, which means that we provided the only opportunity for them to do medicine. And the vast majority of those students were African-American students. And the way we do that is through a secondary application. We ask students to really itemize why they want to do medicine. Are they from an underserved circumstance? Are they willing to serve in an underserved circumstance? And I think it goes back to the fact that if you really do want to find diverse students and give them an opportunity, your process has to reflect that. And so we think it's extremely important. And you can see that the percentage of our class where the Howard student was, we were the only school that accepted them, is significant. It has stayed over 50-something% and has been as high as 80% as well. And these students, you may say on the back end, is that really helpful, well, they are matching on the back end well. So there's some of the impacts on diversity. The first is that I think the pandemic has spurred a recognition of health disparities experienced by communities of color throughout. And when you look at Black Americans were more than twice as likely to die from COVID. And that has really impacted the Black community significantly. In DC, when you look at Ward 7 and 8 in DC, which is just a few miles away from Ward 3, a Black man who lives there in the nation's capital is going to live 20 years less than a white woman in Ward 3. That disparity is unbelievable in the nation, in the US capital, is absolutely shocking. So sometimes we think of access in rural areas, or we think of access in different ways, but the fact that in our nation's capital, we have that type of gap in life expectancy as a result of access, it means that we have a problem. And improving that diversity in the medical school because of the cultural competency that could come with it is important. And so we certainly have to recognize that Black males in particular represent a significantly low number of students in medical school, and that continued effort to increase that representation is important. And I've written about this a lot, that we still need to, although we've had this increase, we still need to be thinking about how we eliminate that bias from medical school admissions. As I mentioned before, there are a few things that we can do. One is clearly the virtual interviews have helped. I think getting students more exposure to the variety of medical schools and options in the country is another one. Finances is another very important one. We received a gift from Bloomberg Philanthropies of about 31.7 million. It was a total of 100 million to the 4 historically Black medical schools. And what this did was to pay down the debt of each medical student who certainly needed that help because of their loans by $100,000 each. And that qualification was important. Now, what we've seen since that is that those students who otherwise would not have taken a chance to do a specialty like neurosurgery or something else where the training was longer because they were concerned about debt that they had to pay off, have started to take those chances. And I think that that's also important as well. And so that support, philanthropic support that has come out of the pandemic has certainly helped to accelerate some of the changes there as well. I think in terms of workforce development and some of the things that we've been trying pre-pandemic and have continued during the pandemic, if not accelerated, is trying to get students more support early on. We have a pre-health scholars program where we bring students from all the HBCUs to Howard every June for about 4 weeks. And these students, every week we give them a practice MCAT. We talk to them about test taking skills, etc. We've seen a significant increase in their MCAT and DAT performance. We do it for dental school as well, is how it started. And this has proven to be very helpful in terms of expanding the number of students that we're seeing applying to medical schools. The other thing of interest is that if you look at the top 20 doctorate granting institutions of Black or African American recipients, Howard is number 1 by a significant margin. And we did that again this past Saturday, graduating some 95 PhD students. We have the largest in-residence program. So trying to expand that program was another thing that we've tried to focus on. And this really got accelerated during the pandemic as well. So we started a program, was initially called the Bias and STEM Scholars Program. And then the Koshes, Bruce and Martha Kosh, have now underwritten this program. We bring students in from high school who are interested in getting a STEM PhD or an MD PhD. These students have a rigorous application and interview process. Their average high school GPA is about 3.89. The average SAT score is close to 1,400. And these students do really, really well when they come to us. They come to us the summer before the other freshmen start. They take an African American Studies course and a STEM course, and then we fly them to an international trip. Obviously, the pandemic disrupted that, but we think we'll be back doing that again this summer. We've been taking them to Berlin, Germany. The vast majority of these students who are Pell Grant eligible do not have a passport, have never been out of the country. And we thought it was important to give them that type of exposure. what I'm extremely happy, and then every summer they go off and do research, and they've been doing research all over the world. What I've been very happy about is the kind of labs that they've been going to. As you can see here, a very diverse group of labs all over the world. Some of the best labs in the country as well. Some of them has gone as far as Vienna, Austria. These students have continued to do well. They've been publishing in major journals and winning awards of a wide variety. And so we've been very proud of them. We have a Goldwater Scholar from last year. I actually just found out we have another Goldwater Scholar again this year as well. Students are winning the NSF Graduate Research Fellowship as well. And this is where the first cohort who graduated last year, this is where they are going to graduate school. As you can see, again, very wide variety, including University of Virginia, Hopkins, Harvard. They're all over the country. Now, what's amazing is number of MD PhD students we have currently in this group is about 30. So if you look at the number of Black MD PhDs in our country, if Howard continues to do this program for the next 10 years successfully, we would probably quadruple the number of Black MD PhDs in the country with just this one program. So pretty excited about this. The other thing is starting the pipeline early is important. We have a middle school on our campus. It's named the Howard University School of Mathematics and Science. So we call it MS Squared. Just for a bit of play on words, the kids who come here usually are performing below the average for the city. 96% of these students actually go on to college. And if you stop one of them, they will tell you that they go to Howard University. They won't tell you they go to Howard University Middle School. But what's great about this is that being on the campus, they're able to go to the dental school, to go to the simulation labs, go to engineering, and that early exposure is important. Again, I think when we look at the pandemic, the number of young people who now have an interest in medicine and science is significant, but we have to harness that. We have to put them into environments, and we've seen an increase in our applications for students wanting to go to the middle school as well. I don't think medicine should be isolated. And so the other thing that we've been looking at is students with non-traditional backgrounds who may want to get involved. Felicia Rashad is now the dean of my Chadwick Boseman College of Fine Arts. We have a Howard Entertainment Project in which we're sending students out to Hollywood. One of the things that we're finding with students is that I'm not as interested in their major as I am in their mission. And so while I was out in LA with these students at Amazon Studios, one of the things that became obvious to me is there were students in this group who were interested in healthcare education and healthcare communications. How do we get the message to students? Students that I think will circle back, probably later on in life and decide to go to medical school as a result there, although this is where they start. And I also get our curriculum needs to be a little more adaptable to try to bring these students in so we get them there. Now, patient-centered care, as I begin to wrap up here, I think is extremely important. I mean, one of the things that my mentor, Dr. LaSalle Ford, used to say all the time is the patient must be the object of our affection. And I think the way medicine has been constructed in the United States for a long while, the physician has been that center. And I think that that's something that we have to relook at. So we have a nursing and allied health school, we have a pharmacy school, and we have a dental school as well. And so interprofessional education has become really important for us, recognizing that we have to look at patients more holistically. And this gentleman was the chair of the Howard University Department of Surgery, the first African-American to serve as national president of the American Cancer Society, the Society of Surgical Oncology, the American College of Surgeons, and I can go on and on. But what's most important is that when he graduated from what was then known as Florida A&M back in 1948, he could only apply to 2 medical schools as a result of the impact of the Flexner Report. He did not get into either medical school, and that would be Howard and Meharry. His college president had to call Howard University's president and petition to get him involved. What was interesting about that, and still is today, is that he had an issue taking standardized tests. He only got one B and graduated from Florida A&M College as an 18-year-old. So it just goes to show that had he not gotten that opportunity, none of the great things that he went on to do would have happened. He graduated with one B on his transcript. So when we think of diversity as well, and we think of opportunity, I hope sometimes we would also think of what are some of the things that we do today that we can potentially change in terms of evaluating students and their potential, because we can miss, gems like him. The other thing that I think is important is community-centered care. I think the pandemic is going to change how medicine is really provided to others, but I think we have an opportunity to also interest a certain diverse group of practitioners into medicine. So for instance, technology. We have a lot of students who are getting into technology today, and we have to keep on impressing upon them that they can apply what they learn to really assist. As we saw in the pandemic, we have to start meeting patients where they are. And I do think we have to start deploying a network of mobile health units to help. We have to start using telemedicine more in more communities with disparities. And along the lines of using technology, I do feel strongly that one of the underutilizations of technology are things that are life-saving. I'm a type 1 diabetic. I use Insulet's Omnipod system. For the sake of full disclosure, I'm on their board, but I was a patient before I got on their board. And that now uses a closed loop system with a continuous glucose monitor. And the fact that you can do that today with a device can be so transformative for communities if they can afford or if they can be impacted by that use of technology. So certainly, I do hope that we would look at that. Also, the social determinants of health, we need to look at differently as well. Our students in my nutrition science program go out into the community and to shop with folks in the community at the major grocery stores. This was an idea that I brought to their dean. I suggested that it would be helpful if they can not only shop with those residents, but then send that information back to their primary care physicians. Everybody thought it was a good idea. We deployed them and the community loved it. But students, being who they are, saw a much better opportunity. They actually decided to do a few things different. One of which was to take that practice to corner stores. And as you could imagine, obviously that's where most people in the neighborhoods that we were sending them to get their groceries. That was transformative as well. They were able to help those shop stewards with where they should position things on the shelf, how to make sure that healthy options were available to those residents, etc. And again, this had a significant impact as well. Our cancer center does a lot of mobile efforts as well in terms of getting out to students, and that's something that we push. The pandemic really pushed us as a university to look at what it meant for diverse communities in terms of these outcomes we were seeing. We started COVID-19 testing and vaccine distribution at Howard. We got a generous grant from Bank of America, and that helped. And most of us don't remember these things now. It's kind of, you've been through so much trauma with COVID, but some of us can recall at the beginning of the crisis, you had to get a prescription from a physician to get a test, right? Now we have home tests, etc. But back then, communities of color were well under-tested, and those were the folks who were going to work. So we decided that we would set up a free testing, no prescription, walk-in, one of the first in DC. And that proved to be very, very valuable for those patients who were very vulnerable. And then in February of 21, we started a vaccine clinic. What was amazing about this picture shows the dean of my nursing school with a 103-year-old patient who was vaccinated by a 19-year-old nursing student. And she could not have been more pleased. Her second pandemic, and as she said, she saw something very different. She doesn't remember as much the first pandemic. She certainly lived through the after effects of it, but she was so humble and warm to be able to come into Howard and have a 19-year-old nursing student vaccinate her. The other thing that was interesting in this process is we actually participated in a vaccine trial for Novavax while we were distributing both the Moderna and Pfizer vaccines. And there was skepticism, even with me, as to whether or not we'd be able to fulfill the number of patients. And being a trusted messenger in the community worked. We were able to hit those enrollment numbers fairly quickly, despite the fact that we were already distributing two approved vaccines. So I think that that was very important. We took this out to the churches. We went into the community with it. And I think, again, as we look at what the pandemic impact is going to be, is that I think these are things that aren't going to go away. We started with vaccinations, but we recognize that we have to continue being out in the community in order to provide services. So as I conclude, there are a couple of things that I do want to point out, because I think you have to be introspective when we, especially when we talk about these tough issues like diversity. So the first is, this is a picture of my deans. When I started, one of my 13 deans was a woman. We now have 14 schools and colleges, and you can quickly see that 10 of my deans are women. I'm about to add one next week. Don't want to get too ahead of myself, but we could end up with 11. And so this process has been a rigorous process of making sure the search committees are gender balanced. Everybody who serves on a search committee has to go to unconscious bias training and cultural competency training. And you know, doing that at Howard is not very popular initially, but everybody who goes comes back and says that they're thankful they did it, because they immediately recognize that it was something that was absolutely necessary, and they did not appreciate their own unconscious biases. This gentleman in the middle here is Charles R. Drew, whose name is on the endowed chair that I hold, the professorship. I told you about Dr. LaFour before, and this lady to the left here is my mom. She became a nurse. She wanted to become a physician. She ended up practicing nursing for 51 years. My grandfather, who was a lawyer, felt that women should become nurses. My mother was against that, but did it. He was a good man. He wasn't right on that particular issue, but she insisted that she wanted to have 3 sons. She wanted one to be a pilot, one to be a physician, and one to be Prime Minister of Trinidad and Tobago. I'm not crazy about politics or heights, so I decided to get into medicine. But this gentleman in the middle, Charles Drew, has a saying that I think is important. Excellence of performance will transcend artificial barriers created by man. And I think that that still is pertinent today. He would die tragically on April 1st, 1950 in a car accident. There's a myth of that, despite the fact that he was the person who discovered and promoted the way to preserve plasma, that he was denied a blood transfusion because he was taken care of at a white hospital in the South. And that's not true. He suffered very, very serious injuries that were not compatible with life. And so his saying and his mantra is something that we at Howard still live with today. Equality, equity, and justice, I think, is what this is about. And I think this pictorial really says it all. You know, we can give everybody the same benefits and not necessarily benefit those who are most compromised among us. Or we can give the benefits that are needed to some. But ultimately, the justice is when we take away the barriers. And I think that's what we all need to work on when we talk about diversity. This is not an issue of quotas, and it's not an issue of just numbers, but it's rather an issue of providing an opportunity, an equal opportunity for everyone in our society to thrive. And I think that that's something that we're fully capable of. I took this picture back in 2008, I believe it was. This is my son and my daughter. My wife would point out that my son is dressed in a surgeon's garb and my daughter was in a sweatshirt, like a cheerleader. So the point I want to make here is that we all have unconscious bias. Sometimes we don't recognize it. And so now I like to close with the future of academic medicine looking like this. My kids will be embarrassed to see these pictures. They're now 17 and 15. My son will be 18 next month, and my daughter will be 16 in July. I took both of them to the operating room for the first time this past fall. And while my son is going to go off to Duke and play Division I soccer, and is going to do economics and finance. When I got back to my office with him after the case, he said, "Dad, I got a rush when you made the decision." So like I said earlier in my talk, hopefully he'll have a circuitous route to medicine. My daughter, on the other hand, is an activist. She wants to be a female orthopedic surgeon who operates only on elite female athletes. So she's going to practice her own gender diversity and bias in some way, shape, or form. So thanks for your attention, and I appreciate the opportunity to speak to you. I'm happy to answer any questions you may have.
Wow, Dr. Frederick, this has been an amazing conversation. These are excellent examples for what other schools can do to encourage diversity within their schools and ultimately the medical workforce nationally. So there was so much data and information. I am super glad that I will be attending tomorrow's session as well, a repeat session at noon. And I want to encourage others to do the same, or encourage your colleagues to attend at 12 o'clock tomorrow as well. We have had to cancel the 5 o'clock session due to Dr. Frederick's busy schedule, but we will also have the video and the presentation online as well on our website. I have some questions myself, but I'd like to open the floor to others who have some questions for Dr. Frederick. You can either type them in the chat and we will convey them, or you can just unmute yourselves and go ahead and ask them yourselves. Anybody? All right, well, I'll start. So Dr. Frederick, I noted that you do encourage, and you in your talk, you encourage telehealth to encourage diversity in healthcare, but I've also heard arguments against telehealth from other folks because of the costs and the lack of resources in underserved communities. Can you comment on reconciling those thoughts a little bit?
Yeah, sure. I think it's a good point, and I don't want to leave that as an unrecognized hurdle, but I think it's a hurdle that we should just tackle. I think we say, we often just kind of throw our arms up and say, well, they don't have the technology, so we shouldn't do it. But the reality is that investment in technology is worth it. And I think that's where our argument should be. We should think of how can we invest in that technology and then go from there. One example is if you use community centers in those communities and you set up that technology so that when patients do have their appointments, they can come to those areas. There are public libraries that have quiet rooms as well, where again, members can go and potentially use it. I think we just have to be more creative about how we get the technology to the patients and then allow them to use it. I think that could be absolutely transformative in terms of their outcomes because of that lack of access. And as well, folks who work, for hourly wages, et cetera, it's a challenge. I operated on a 40-year-old woman with breast cancer when I first came back to Howard, and she did not show up for her chemotherapy appointment. And I was really unhappy with her. And I remember calling her up, kind of really, disappointed and saying to her, well, why didn't you, show up? And she calmly said to me, Dr. Frederick, I had to go to work because, it's coming close to the end of the month. I've got my kids to feed and I'm not able to do that. And I was so embarrassed that it never occurred to me to stop myself long enough to recognize the circumstances she was in, and that my asking her to show up for an appointment and not go to work, which, seemed life-saving, was really not her most important priority. And I had done nothing to not only investigate that, but to help her mitigate that circumstance. And I think that that's problematic as well. And we have to look at our system more aggressively, I think, to bring those resources to those who need them.
Absolutely. I love your comments throughout your discussion on not only for healthcare. So this is a perfect parallel for getting the healthcare to folks, but providing the ongoing resources for supporting their development and their success. And you exemplified that, for medical education. So it's not just about recruitment, right? It's about supporting folks once they get here or wherever here may be, supporting them with the resources they need to be successful in those areas. I think that's a point that's often lacking. When we focus a lot on recruitment numbers, we've got to retain the diverse population that we're interested in keeping and ultimately expanding our workforce. So I love that. Dr. Nussbaum, you're on mute. We're always on mute.
Yeah. Wayne, welcome to Roanoke. I really appreciated your comments today. I was interested in your point about the virtual interviews and how that was a benefit to particularly, those students and residents that don't have the means to travel across the country. Is it your sense that once we're out of the pandemic, is there going to be advocacy for continuing to do virtual interviews at all levels, or do you think we're going to go back to insisting on having students travel around the country to interview? Because we've seen the same thing just in our ability to attract a more diverse group of residents over the last 2 years, as we've really benefited by that.
Yeah, I think we're going to go back. We're creatures of habit. So I do think we're going to go back. And while I'm a big advocate, I'm sure even Howard is going to go back. I am going to advocate for us not necessarily going back, for us really trying to assess the situation, or even if we go back, to be mindful of the dynamic that might be at play, that one's, all students may not have the resources to do all that travel. And two, that even when we bring students, we don't create circumstances where, they may be intimidated. I think that leaving students in a room to interact with one another, always worries me because, you have introverts amongst that group, including myself. And as you know, with introverts, we want to be around people because I would say the essence of the human condition is interaction. We just don't want them to talk to us. And so when you look at situations like that, I don't think it's a good setup. I think when we bring students in the morning before they interview, we have to think of different programming and different ways to engage them so that they go into the interviews as confident as possible and not lose that. And the last thing I'll say about this is that it happens at every level. I interviewed for fellowship to do surgical oncology, and I will leave the institution unnamed, but one of the events the night before was going to have cocktails. At that time, I didn't drink. And being an introvert, I went to the corner of the room, had some sparkling water, and waited for people to come and say hi. The current fellows walked around looking at how many people you interacted with and making kind of a note of that. And the next day, one of the questions in one of the rooms was, did you meet someone last night you didn't previously know who you would like to train with? Well, that's a tough setting for me to do that. So I met one guy, Dave Kubi, and fortunately, he also gave my name as well. And so we lucked out. But the reality is that that's not the right setup, right? And then the second thing, at that same site, when I interviewed, one of the questions was they showed you a picture of an older photograph, so from probably the 1930s, even 1800s, of a white man in black and white. And I just guessed one of the surgeons who won the Nobel Prize. It turned out to be William Harrison, the president with the shortest tenure, because he gave a very long inauguration speech in the cold, got pneumonia, and died. Well, being from Trinidad, my American president history wasn't the best. And so using those techniques in an interview immediately are going to eliminate someone like me. So I think if we're just thoughtful about how we set it up, what we're looking for, and also training people to interview, right? A lot of times people sign up, they're on the admissions committee, and they just go for it. But we really have to start thinking of, listen, these are not questions that are appropriate. And as a matter of fact, these are questions that are really helpful. So I think we will go back. That's a long slide to tell you that I think we will go back. But I think if we do, I hope we pay a lot more attention to how we set these things up so that we get a better, outcome.
Those are great thoughts. Great thoughts. Dr. Hartman has a question in the chat. Dr. Hartman, did you want to ask the question? I noticed you turned your video on. Did you want to ask the question yourself?
Sure. I'm David Hartman. I actually am blind myself, and I was curious of your thoughts about diversity in terms of physically disabled people getting into medical school.
Yeah, absolutely. I think this is a very good thought. Again, I think we have to be purposeful about recruiting, recruiting that population. And so I have a couple of thoughts about it that is a bit related to my own circumstance as well. I have sickle cell, and when I applied to do general surgery, as you know, we had a pyramid program. And so everybody discouraged me from doing it because they were like, you're not going to have the stamina to do it. You're not going to be able to, do long operations, et cetera. And I recognized during that process, to your point, that we didn't have a system that was very accommodating to any type of disability that someone may have. As a matter of fact, people encouraged me not to put it in my personal statement, et cetera, which I think was a mistake, because I do think that people with disabilities can relate to patient populations very differently and actually make excellent providers. So I do think that we have to go out and recruit. I do think we have to look at our setup and systems and make sure that we can accommodate how to train well enough so that we can accommodate that patient population. But I think on the front end, we have to make an effort to recruit and to ask of those physicians like yourself to give us input on what would help. What would be the things that you would need that would best help you? One of the most transformative experiences I've had in my life is going to Cape Town, South Africa with my law school and witnessing a blind former judge who helped write the Constitution give a lecture. I was fascinated. He and his wife partner, he uses a system to lecture. It was one of the most riveting lectures I've ever been in. And I remember coming back and talking to my team about how many people we eliminate from our system only because we don't have the vision, the wideness or the wide enough aperture to say to ourselves, the talent is going to come in diverse forms, and let's accommodate and make sure we're doing the right things. And so I'm fully supportive of us looking at it, but I think it has to be a system issue. And on the front end, we have to be actively recruiting.
Thank you.
Dr. Bishop made an excellent comment in the chat. Dr. Bishop, did you want to unmute yourself and make this comment, or do you want me to go ahead and read it? I can do it. I'm looking for an L somewhere. Oh, there he is. He may be driving. He is always in between meetings.
You can go ahead. Please
Okay.
feel free to go ahead.
Okay, great. So this was an excellent presentation, and thank you. It is interesting that the hospital here in Roanoke for Black citizens was begun to honor Dr. Isaac Burrell, who was sent to Freedman Hospital in 1914 due to segregation. He did not survive surgery, and his passing pointed to a need for a hospital to serve the Black community. The hospital was named Burrell Memorial and was known for its excellence in nursing and other areas, and it's more than 50-year history.
That's
Great comment. Thank you, Dr. Bishop. Any other questions, concerns, comments before we close this lovely discussion? As a reminder, tomorrow at noon is our repeated session. I'm telling you, there was so much great information throughout the discussion that I was like, oh, well, at least I'll catch that tomorrow. I'll be able to reflect on that a little bit better in between sessions, and we talk about it tomorrow. So. All right. Well, thank you all so much for joining us. I hope you have a wonderful, beautiful day. And Dr. Frederick, thank you again for being here with us, and we look forward to your discussion tomorrow.
Sure. It was my pleasure. Look forward to seeing you tomorrow.
Great.